All right, so in this lecture, we're going to talk about drugs for endocrine disorders, and that pretty much covers the pituitary, thyroid, adrenal glands, and diabetes. So we're talking about the endocrine system. Really, the main role and focus would be this hormonal regulation. And so there are hormones that are responsible for many, many things in our body, but one hormone may control the secretion of another hormone. And so it's really important in maintaining homeostasis, or that equilibrium of the body. And so there is a lot of negative feedback loops in terms of preventing oversecretion. And so it sort of just stops or slows that process. Some hormones only have a few receptors. So we talk about oxytocin or parathyroid hormone. They're very specialized, very individualized. So when we think about oxytocin, and if you've heard of women who are lactating or breastfeeding, this is a hormone that is sort of specialized to breastfeeding. And so we have a lot of receptors such as thyroid and insulin. This is a video here. If you click on the slide, an arrow will come up for you to sort of play this video. All right, so I think my previous recording on this slide erased. So let me start over in talking about the glands on this diagram. This is a really good visual representation to see the glands of the endocrine system. And I want you to realize that the thyroid gland is really important in producing 3 hormones. But when we're talking about sort of that master gland of the body, the master gland would be the pituitary gland. And that's the master gland because it stimulates other glands to make hormones. The parathyroid is really responsible for calcium, equilibrium and secretion, and is really responsible for that bone mineralization. And then we have our adrenal glands, which comprised of sort of 2 parts. We have the adrenal medulla, which is responsible for epinephrine and norepinephrine. So remember that fight or flight response. And then the adrenal cortex, which are responsible for glucocorticoids, mineral corticoids, and sex hormones. So this diagram here sort of gives the overview of the glands and the major hormones, as well as the target organs and effects that these glands may have. And I won't go over these individually. So moving into the role of glucose, this is something that is sort of really important because diabetes is increased. It's one of those things that is becoming more prevalent as obesity rises and increases in the United States. And the organ responsible for glucose maintenance would be the pancreas. And the pancreas regulates blood sugar levels via glucagon and insulin. And so insulin carries glucose out of the blood and into your cells. And once the glucose is into the cell, that is when it is utilized for metabolism and other processes of the body. So it produces energy, and it's sort of that main energy source of the body and the brain. The brain is one of those organs that is pretty independent. Without glucose, it will die, and it doesn't have cells within itself to produce glucose within the brain. So glucose is something that crosses the blood-brain barrier in order to reach the patient. And so the specialized cells of the pancreas are called the Langerhans, so the islets of Langerhans. And when we're talking about this regulation of blood glucose, glucagon is something that is really important because it increases blood sugar and insulin decreases it. So you can sort of see this balance between the hormones, glucagon and insulin. And insulin is the key to get glucose into the cell. So when we think about sort of that lock and key mechanism, the target cells, the target receptors, when insulin is locked into that target cell, that is what allows the glucose to enter. And there are specific drugs that can interfere with glucose levels, as well as other disease processes occurring within the body. So for example, if a patient is hypoglycemic and not taking any insulin, one of the first things that comes to my mind would be their kidney function, because the insulin is excreted through the kidneys. And so if the kidneys aren't functioning correctly, the patient may have an increased chance of hypoglycemic or low blood sugar episodes. And so what we can see here is sort of the diagram, the compare and contrast of diabetes type 1 versus diabetes type 2. And normally the blood sugar is 70 to 110. When we talk about type 1, this is really that genetic component. It's thought to start earlier on in childhood. There's also another peak increase of onset during puberty. So this is little to no insulin. These patients that are type 1 diabetic will need insulin for the rest of their life. It's sort of thought to be autoimmune in nature. Type 2, there are factors that go into type 2 diabetes, genetics, familial history or family history, as well as age. Just as the pancreas ages, the function decreases. And then with obesity, so think about the insult of high blood glucose and sort of a poor uncontrolled diet. The pancreas is having to work overdrive and eventually becomes tired and can no longer keep up with the metabolic demands of the body. So this slide here sort of summarizes the things that I've already mentioned in terms of sort of that genetic predisposition and obesity, but the beta cells in the pancreas are the cells that are responsible for releasing insulin, as opposed to the alpha cells, which release glucagon. So to summarize, type 2 diabetes drugs for type 2 cannot be used for type 1. And why is this? It's because they are different in nature. Remember, type 1 diabetics are not producing insulin, as opposed to type 2 diabetics, which they are making insulin, but there are issues with the glucose being absorbed into the cells. And so sometimes with type 2, they may need oral anti-diabetic drugs such as metformin, in addition to insulins. And so diet and exercise for type 2 diabetics when they are in the earlier stages, or something which is called metabolic syndrome stages, diet and exercise would be the most preventable way to control the blood sugar. And if with diet and exercise the patient is not able to control their blood sugar levels, then treatment with the anti-diabetic drugs and or insulin would be necessary. You really want to the lab values during treatment. One of the labs that you may hear at one point in your nursing career would be a hemoglobin A1C, and that is a measure of the patient's blood glucose over the last 3 months, and it's that average for the last 3 months. And really the goal for treatment is to really control that blood glucose, and we want to increase the insulin sensitivity. By increasing insulin sensitivity, we allow for the glucose to be absorbed into the cells to be utilized for the metabolic processes of the body. And so we really want to have that homeostasis between the insulin and the glucagon. And so some of the goals would be to inhibit hepatic gluconeogenesis. This is a diagram here that indicates the types of non-insulin agents for diabetes treatment. And what we can see here is that most of them are oral agents. In order for these medications to be most well absorbed, they need to be digested and broken down through the digestive process. So, as I mentioned earlier, insulin is mostly for type 1 diabetics, but is very commonly utilized for type 2 diabetics if oral agents are ineffective. We want to be cautious of potassium levels. The goal would be better glucose control. And sort of an example here would be Similan. Your types of insulin would be Lispro as an example, and this is really that rapid acting insulin. We have that peak of onset of 15 to 30 minutes, in addition to regular or short. Regular insulin is the only insulin that can be given IV, and it is known as a clear insulin, which will be relevant when you are in the nursing program and learning how to administer or mix different types of insulin. So NPH would be that intermediate acting, and the goal behind NPH is really that there is not a peak. It sort of starts to work and then stabilizes as if it was acting like the pancreas throughout the body. And so this is more of that cloudy form of insulin. And then we go on to our Lantus. And so the Lantus is one that you would never want to mix. And this is also a clear insulin. It's a long acting. So I mentioned sort of that peak of the fast acting, intermediate acting, and the long acting. And this is a very good diagram that shows the peak, the onset, the peak, and the duration. It's really important as nurses, we know that all of these categories, but especially the onset and the peak. We don't want the patient to have a hypoglycemic episode and us not go back to check on the patient. It's important with the subcutaneous injections of insulin that we rotate the sites to avoid scar tissue. You really want to monitor the patient, like I said, for those signs and symptoms of hypoglycemia, which would be cool, clammy skin, and later on increased heart rate or confusion. If the patient is hypoglycemic, we want to treat the patient with glucagon IM or D50, which would be IV. If the patient is alert and oriented, treatment can be as simple as orange juice paired with a protein such as a string cheese, and then a recheck of the blood glucose within 30 minutes. So shifting gears here into the thyroid hormone or the thyroid gland, we can see here that there are a few other sort of glands that are responsible or near the thyroid gland that sort of work in conjunction with one another. So the thyroid gland secretes hormones that affect nearly every cell in the body, and that's why it's really important that we have a good understanding of the thyroid gland and the hormones that it secretes. It's really, when we're talking about what is it responsible for, the T3, T4, I want you to think about the metabolic rate. And so hyperthyroidism increases the metabolic rate, as opposed to hypothyroidism or slow would decrease the metabolic rate. It's really important for normal growth and developments in infants and children. It's something that is checked when an infant is born to ensure adequate development and growth process. It can strongly affect the GI, cardiac system, and neuromuscular function. What we can see here is another diagram version of what we just learned about, but it's more specifically keying in on the role of iodine in order to synthesize T3 and T4. Our body needs iodine. We usually get enough through dietary supplementation, but it may be one of those things that we may need additional supplementation. So I mentioned hypothyroidism or slow thyroid. Remember, when we think of slow and slow metabolic process, everything in the body is slowing down or stopping. This diagram does a really good job at depicting some of the signs and symptoms that the patient may have with hypothyroidism. So the muscle aches and weakness, hair loss, intolerance to cold, thick tongue, slow speech, anorexia. So these are things that sort of occur slow and over time. And a lot of times the patients, if some of the earlier signs are lethargy or tiredness or constipation, those signs and symptoms aren't severe enough to prompt the physician to sort of treat these patients. And so the later signs here would be that slower heart rate and weight gain. And that's usually when the patients go in, is when they are symptomatic, such as the slower heart rate and weight gain. And so again, if the patient has a lower thyroid, we may need to supplement with iodine or sometimes medications. And so Hashimoto's thyroiditis would be one of the more common forms of hypothyroidism. So when we're talking about low thyroid or hypothyroidism, really Synthroid is probably the most common treatment for hypothyroidism. It can come orally, IV, or intramuscularly as the 3 routes of administration. One of the few drugs that many patients say they cannot take the generic version. So that's really important when we're considering the cost and considerations for administering this medication to this patient. Now on the flip side here, we're talking about hyperthyroidism. And so this hyperthyroidism would be when it is too much energy, too fast. So Graves' disease would be one of the more common forms of that hyperthyroidism, and we have too much T3 and T4. It can also be decreased depending on what stages that the patient is in. But when I'm talking about hyperthyroidism, some of the signs and symptoms would be tremors, sort of the bulging of the eyes. I would say that's probably one of the more common characteristics, as well as the enlarged thyroid. So something such as a goiter may be known or common to the patient. And so we'll go on. All right, so talking about hyperthyroidism and the treatment of hyperthyroidism, when we're talking about sort of the life-threatening storm that can occur, it's called thyroid storm. And the fever or the heart rate tachycardia, hypertension would be sort of that common classic signs and symptom. We want to treat the patient's symptoms such as the high heart rate with things like a beta blocker, and then for treatment of the hyperthyroidism itself, the PTU or the Tapazole, these medications cannot be given during pregnancy. Also, in terms of treatment, surgical removal of the thyroid gland or destruction of the gland with radioactive iodine are also possible forms of treatment. Okay, now moving on to the adrenal glands. Remember that epinephrine, norepinephrine by the adrenal medulla. And what we can see is that the adrenal medulla is, or inside of the adrenal gland, which is right on top of the kidneys. So if you think about the kidneys as almost wearing a little hat, the adrenals would be the hat of the kidneys. And so the hormones secreted would be that epinephrine, norepinephrine. Remember that fight or flight, so that increase of body responses. And then we have that corticosteroid secretion. So the glucocorticoids, there's roughly over 30 types that are secreted by the adrenals. And the most familiar type would be cortisol, and that's sort of that stress hormone. Then we talk about the corticosteroids such as also the glucocorticoids, mineralocorticoids, and the sex hormones. I previously mentioned the glucocorticoids, but the three of the corticosteroids would be the three that I just mentioned. And so in the note section, you will see that there's a pretty good description of what the hormones do. But the effects of the adrenals, we talk about the increased blood glucose or the increased breakdown of lipids or those fat molecules and protein, as well as bone demineralization and bronchodilation. So what we can see here and learn from this slide is that the adrenals are pretty much responsible for a lot of major and key functions within the body. And then we talk about corticosteroids for Addison's disease. And this is one of the pretty common characteristics of an autoimmune destruction of the adrenal glands. And so when we have this adrenal insufficiency, we must replace it with corticosteroids. So treatment with Solu-Cortef or hydrocortisone, prednisone, or dexamethasone. Remember, we have low steroids, so we need to increase them in the body. And so these act as an anti-inflammatory. But one of the things that we need to educate our patients on is that these corticosteroids cannot be abruptly stopped. Steroids are something that need to be tapered down or tapered off over time. So key points to remember in wrapping up some of this. Hormones are chemical messengers. We need to focus in on that negative feedback loop and the hypo or hyper states. So the slow or fast states exist. Crisis such as thyroid storm can be fatal, and the patient should be educated on all the signs and symptoms opposite of a condition. Remember, if an organ or a gland fails, they may have the extreme lower case of certain disorders or conditions. And your endocrine system is very important. So sort of in here with, may your endocrine system function forever. Moving on to these questions or answers here, I will leave my notes up on the slides, but the main elements of the endocrine system are the glands, hormones, and cell receptors. Which finding is a sign or symptom of hypothyroidism? And the answer here would be B, bradycardia. Remember, bradycardia was one of those later symptoms that is usually the first symptom the patient comes in and reports in addition to the weight gain. True or false? Synthroid is fast acting and becomes effective after a few days. The answer here is false. And the thyroid gland secretes T3, T4, calcitonin for proper regulation of metabolism. The answer to this question here would be D, start on a low dose, which will gradually be increased. That's really important when we're talking about synth rates. Start low and slow. And then insulin is released when the blood glucose increases. Remember, insulin is sort of that hormone that lowers the blood glucose. And the answer here would be D to this question. Remember, I'm here for you guys. Reach out if you need anything. The PowerPoints for the drugs for bone, joint, skin, eyes, and ears. It's a combined PowerPoint. I have already completed that PowerPoint and both will be uploaded. So happy studying. Please reach out to me if you have any additional questions. Email. You always are welcome during my student hours. I would be more than happy to confer Zoom with any one of you. And final exam review will be posted soon, so keep an eye out for that. I will post an announcement once it's posted up to Canvas. Thought that was the last slide, but last but not least, the answer to this question would be C.